and then we'll start our discussion.
ISD closure. And through a transpulmonary approach, we further resect infundibular muscle in this region. There, you might take out a very small septal band in this region, but leave the major septal band, and then focus on this region over here from the surgeon's perspective, where you make sure there's very thinned out muscle from the tricuspid valve annulus all the way to the pulmonary valve. Next. But then a decision has to be made. And I think about this as really the lost or forgotten infundibular chamber. This is an example of what the infundibular chamber looks like on 3 patients. So in this patient, you have a very large infundibular chamber, which would suggest that nobody would perform a transannular patch and there would be no outlet obstruction. This would be a very pink tetralogy. This is a much smaller and elongated infundibular chamber with a very borderline sized pulmonary valve. That may or may not require a transannular patch. And then you have this one in between where pulmonary valve is quite reasonable, but you may have to enlarge the infundibular chamber to leave you only one site of potential obstruction, that being the pulmonary valve area annulus itself. So we set it, next slide, please. We set about to do this in the late 1990s, trying to preserve the pulmonary annulus on literally every patient. And it turns out there are about 10% of patients that there was no hope and we didn't even try. But ultimately, we were able to do a full transatrial transpulmonary repair in about half the patients. And then another approximately third of the patients we added in this infundibular patch. And what I'm going to talk about today is what we discovered. So because there was a change in practice in a fairly short period of time, it allows you to have a good look at the differences. So the conventional group, this is the annulus preservation rate based on pulmonary valve annulus to pulmonary body surface area. And here you can see the annulus preservation group looks very different. And of course, what we're interested in is what we would call the marginal patients, or those patients who, based on surgical strategy, could have gone down either choice. And if you look in the upper right-hand column, you can see indeed there's quite a difference in the rate of annulus preservation. This is early outcomes based on echo findings at 16 months. You can already start to see an improvement of right ventricular end diastolic dimension to left ventricular end diastolic dimension ratio. In other words, the right ventricles were smaller. And of course, there were slightly higher gradients in those who had annulus preservation than those that don't. But when the data becomes interesting is when you start looking at what do MRIs show at 10 to 15 years. And Priska Porndorfer was a medical student at the time who came and assembled all this data for us and did some fairly sophisticated analysis, which I'm going to show you today. So we looked at 185 total patients, and you can see we had follow-up of kind of 10 to 15 year range, and we were able to do very tight matching of patients using a regression model looking at annulus size, pulmonary main pulmonary artery size, and the left pulmonary artery size, and look at only the marginal patients. So the right-hand portion of this panel shows in this territory, nearly everybody would have a transannular patch. In this territory, virtually nobody would have a transannular patch. And then in this middle zone, it clearly was surgeon choice or surgeon strategy that allowed you to make your decisions. And so therefore, let's see what happened to those patients. And here's what happened to those patients when you look at their MRI volumes on these propensity matched patients, 30 in each area. You can see the annulus preservation group had MRI volumes in the range of 120 to 130. And those who had the standard repair had those big boggy ventricles that we talked about earlier with very large right ventricular volumes. Not only was it important for the right ventricle, but it turned out it was important for the left ventricle. When you looked at these patients who, on a propensity match basis, could have gone either way, you can see each of these categories. You had better left ventricular stroke work, you had better LV mass, and so forth. So it was not only helpful to the right ventricle, but it was also helpful to the left ventricle. Now, this is what one of the things I was worried about when we started this was that we would have quite a number of reoperations for obstruction to the right ventricular outflow tract. And in fact, that turned out to be true. About 6% of the patients had early reoperations for right ventricular outflow obstruction, where they would come back in 6 months or 18 months with outflow obstruction that you just had to re-resect or perform a transannular patch. But what's more interesting is when you get out to 10 to 15 years, you see a dramatic difference in the number of patients who are now having pulmonary valve implantation. Remember, these are the propensity matched patients, so they are equivalent anatomy coming in, but they are performing and behaving differently when you get out to 10 to 15 years. Now, I don't want to say this is better than what it actually is, because in fact, if you track their right ventricular end diastolic volume over time, those who have annulus preservation clearly do not have normal ventricles. You can see on the bottom of this curve that they also increase their volumes over time, but at any given point in time, they tend to have smaller volumes. So what's going on in the world? How's the world performing with tetralogy of flow repair? So this is a European journal publication on the European database in 2012. 60% of patients are having the old-fashioned surgery, and about 40% of patients are having something more in the modern range. And you can say, well, this is very old data. Well, it is. Marshall Jacobs at the World Congress in Barcelona actually updated this on a verbal basis, and the numbers were exactly the same. So we still have an issue within our society in terms of, are we going to do classic repairs or are we going to move on? And part of this is because we don't have strong enough data. And so in partnership with McMaster University, Sarah Hussein, who is now a surgical resident in cardiac surgery, has helped us put together a large tetralogy of flow for life study globally. We've enrolled over 1,000 patients. We're now in the follow-up phase. But interestingly enough, this is what we find. When you study it, all of a sudden everybody starts working on preserving the annulus or doing more modern mini transannular patch type surgeries, which is really good news. So here you can see in this study about 60% of patients are having annulus preservation, and only about 20% are having the old classic type of repair. So we hope to have good follow-up data on that in another year or two to see whether or not these more modern surgeries are having as much impact as we want. The reality is, though, is that we need to have patient-specific design surgery. And Leslie Louvel's a bioengineering PhD student in Toronto who is working on collecting data sets and creating computer fluid dynamic models, computational studies, and now creating patient-specific surgery models to predict who has the most efficiency and what are the optimal operations. And the only thing I would say to this is it's the future, very, very much so, patient-specific surgery. If any of you have data sets on pre- and postoperative CTs or MRIs combined, so pre- and postoperative, Leslie can work on putting this into creating more fidelity into this model. And I would suggest, if possible, contact me or Hart University afterwards. I think this would be a great global project for us to work on. So ultimately, we want to have a paint-by-the-number surgery, getting the most we can for any individual patient based on their preoperative data. And I think what we can say is this surgery, except in the 10 to 20% that we have to do this type of approach because of pulmonary atresia, is fairly obsolete. I can't tell you which of these other surgeries is best. We can make some rationales about that, but ultimately we need to determine this based on data. And hopefully this tetralogy flow for life study will help us in that regard. Certainly, more modern surgeries produce healthier right ventricles that are smaller and that have better function. Surprisingly, it helps, not surprisingly, but it helps the left ventricle as well. There are less early reoperations. And I didn't show you the data, but it actually appears there's better exercise tolerance as well. And I'll end with that. Thank you.
Thank you, Glenn, for outlining the annulus sparing approach and how you've been able to lower the rates of transannular patch repair from 70% down to 30%. Can you outline to us how you assess the pulmonic valve and the right ventricular outflow tract preoperatively and during the operation to determine who you feel is suitable for the transannular sparing approach? And perhaps we could bring Luke in, because I note that in your 2018 paper with Ed Hickey, you noted that the echocardiogram underestimates the pulmonic annulus.
And so I think the important step we made was we said we're going to functionally test every pulmonary annulus to see whether or not we can make it work, which is very different than saying we're going to anatomically measure what happens. So we've learned this from MRI data in small left ventricles, for example. The functional capacity of the small left ventricle may actually be different than what you're measuring anatomically. So the idea was to say, let's look at every annulus, let's do the valvotomies, let's do inverted Y incisions to enlarge, or maybe go into more than one sinus to enlarge the outflow, and then resect and relieve all the subvalve obstruction you can if you need to. So you can add in, you can enlarge the infundibular chamber substantially with a patch on it without making it so big that you could have closed the VSD through. And ultimately what the data shows is that it's actually the pulmonary outlet area that determines whether or not you have too much obstruction. And the only way to really know that is to functionally test it. Z values of -3 are typically used, but you can definitely go smaller than that if you push the limits. And there are people around the world that do this because they are willing to have the patience to go through the stepwise process and sometimes multiple pump runs to get there.
As you say in your paper and in the talk, aggressive attempts to preserve the annulus at times can lead to a higher prevalence. What do you think are the potential future issues specific to the annular sparing repair for our patients as we move forward?
So Andrew has brought up to me a very interesting one, are we creating between our small infundibular patch and the pulmonary artery some residual muscle that will wind up being a nidus for flutter, for example, or ventricular arrhythmias of some sort? I suppose that's possible. We haven't yet seen it, but that's one of the things you worry about. And then unequivocally, there's a number of patients that leave the operating room okay, but then come back in a few months or a year or 2 or 3 with obstruction that is too much, where they haven't continued to improve over time. So that is a cost you pay, but that is particularly why this 10 to 15 year data is interesting, because it doesn't appear to be an outsized cost. It still appears to be protective despite the fact that some patients develop obstruction.
Well, thanks very much, Glenn. I think in the interest of time, we'll move on to our next speaker, and I have the pleasure of introducing Dr. Andrew Reddington. And as you know, Dr. Reddington is Chief of Pediatric Cardiology and Co-Director of the Heart Institute at Cincinnati Children's Hospital. And he's going to talk to us now about have the guidelines for pulmonic valve replacement got it all wrong? Take it away, Andrew.
Thanks, Jonathan. I hope you can hear me. I can't see my slides yet. It says I have control, so it's convincing me I have control, but I'm not actually able to control it.
So, Andrew, eventually I was able to by hitting the next button.
Oh, there you go. So, thanks very much, Jonathan, and welcome, everybody. Greetings from Cincinnati, be it the morning, the afternoon, the evening, or the middle of the night for wherever you are. It's incredible to me to see that we've got 1,150 people joining us right now. Certainly I think the biggest audience I've ever spoken to, I suspect, for any of the panelists. And it's a sign of the times, I guess, that so many of you have got nothing better to do than listen to us drone on. But anyway, I'm delighted to answer this question as to whether the current guidelines for pulmonary valve replacement got it all wrong, and really just sort of set the scene for what we're going to talk about for the rest of the webinar today. Now, as what do I do? Just keep pressing?
Try hitting N on your keyboard, Andrew. That worked for me after a bit.
Hitting what? N?
N, yeah.
I'm trying to press forward, but nothing's happening. N?
Try clicking using your mouse, please.
Say that again? Oh, there you go.
Using your mouse, there you go.
So I just click on the mouse?
Yeah.
Great, thank you. So by way of introduction, I'm even older than Dr. Van Arsdell, so I can remember when I was a fellow that the issue of pulmonary incompetence and right ventricular dysfunction in tetralogy was completely dismissed. It was thought to be an innocent bystander of the operation, and everybody concentrated on relieving obstruction, frankly, at the cost of free pulmonary incompetence in just about everybody. And then in the early 90s, my group with Michael Gatzoulis, Shay Cullen, Rajiv Chaturvedi, and many others around the world, certainly not taking very much credit for this, really challenged the dogma that pulmonary incompetence, in fact, was actually one of the most important prerequisites for the adverse outcomes that we see in our patients as we follow them into adult life with tetralogy of Fallot. We introduced this idea that the electrical substrate of the heart and the mechanical substrate of the heart conspired together and were interrelated to produce some of those adverse outcomes. And as you've also heard, there's been a complete change in our outlook from a situation where relatively few pulmonary valve replacements were performed after repair of tetralogy of Fallot to where we're now discussing, I think, essentially all patients at some point in their life requiring it. Now, this paper very nicely, I think, summarizes the current state of the thinking in terms of the guidelines that we're discussing today. And this is work that Justin Tretter, from one of our speakers, Doc McElhenney, put together a couple of years ago, looking at the AHA, the EM indicator cohort group's thoughts. And fundamentally, they're very similar. There is a threshold for right ventricular volume. It sometimes incorporates aspects of right ventricular function. The QRS duration comes and goes in the various recommendations. And I suspect we all use some combination of those criteria to decide in the asymptomatic patient when to place a pulmonary valve by surgery or in the catheter lab. Now, I've been asked to respond to the question as to whether these guidelines have got it all wrong. Well, in essence, not always, for sure. This is what we can expect if we adhere to those guidelines. Most of the patients, if we get it right, if the ventricle has not enlarged too much, will show reverse right ventricular remodeling back to or close to a normal right ventricular size. I must say it's to the chagrin of our specialty that the exercise data, given the number of pulmonary valve replacements we've done surgically and in the cath lab, are not really very definitive, but it's fair to say that just about every study that's looked at it, even in small numbers, have shown that the patient's exercise tolerance tends to improve after a pulmonary valve replacement, and nearly all the patients are very polite and tell us that their symptoms are much better as a result of having their pulmonary valve replaced. Now, all of that, in theory, should therefore lead to better overall outcomes in terms of hard clinical endpoints. The problem with that theory is that there are some ugly facts emerging in terms of the veracity and the utility of those guidelines in terms of those hard clinical endpoints. And if you only look at one paper from my talk, I think this is a really very, very valuable paper, again, coming from the indicator cohort study group. It's a propensity score adjusted analysis of outcomes for pulmonary valve replacement, looking at those hard clinical endpoints: mortality, aborted sudden death, sustained VT, and the incidence of deteriorating NYHA class or overt heart failure. And the ugly fact that gets in the way of the beautiful theory is that when we look at those hard clinical endpoints, even using the most conservative of criteria, we don't impact the incidence of those hard clinical endpoints by performing a pulmonary valve replacement. Now, interestingly, for those that think, well, we need to do it earlier, if you don't fulfill the criteria, that is, you tend to have a lower end systolic volume, lower end diastolic volume, a higher ejection fraction, for example, maybe a shorter QRS, you actually have worse outcomes. It favors no pulmonary valve replacement when you relax those guidelines. So we have a real catch-22 here. Pulmonary valve replacement doesn't seem to be affecting hard clinical endpoints. But if you do it early, as with most operations, if you don't need it in the first place, all you do is buy the complications of the operation and you don't get the benefits. And so these data are really throwing into question our approach to these patients. This is their conclusion. Large multi-center cohort. Pulmonary valve replacement was not associated with a reduced rate of death, sustained VT, and additionally, there were more events after pulmonary valve replacement compared with no pulmonary valve replacement in subjects not meeting the consensus criteria. These were Tau-Geber's criteria, which actually are a little bit stricter than many. So this entire cohort, the indicator cohort, is really giving us a lot of information. And now this looks at the whole situation in a slightly different way. This is a lovely paper from a couple of years ago, looking at preoperative predictors, our standard risk analysis for those late outcomes, those hard clinical endpoints after pulmonary valve replacement. So a slightly different way of looking at it. But the bottom line is equally depressing. Right ventricular volumes, left ventricular function, QRS duration, pulmonary regurgitant fraction were not predictive of outcomes in these patients undergoing pulmonary valve replacement, suggesting there's something that we need to know better if we are to modify some of the outcomes of sudden death, ventricular arrhythmia, heart failure. Now, what this group are producing are a series of different risk factors for those hard clinical endpoints. I will take some challenge to them in terms of whether these are true biomarkers, but there are certainly signals there that we would be foolish to ignore. Now, you may not be able to read this, but essentially what they say is that reduced right ventricular ejection fraction, increased right ventricular mass volume ratio, and age over 28 years at the time of pulmonary valve replacement are all significantly associated with those worse hard clinical endpoints. So we were asked to write an editorial, Justin Tretter and I, in regard to this paper. And the question we were asked for the editorial was, is it time to throw out those standard guidelines for pulmonary valve replacement and perhaps use some of the biomarkers suggested by the indicator group? Well, first and foremost, we have to understand what a biomarker is, and I'm not going to go into any great detail, but fundamentally, I think this is a lovely description. It should be, if it's going to be a surrogate endpoint, an accurate marker that predicts clinical outcome, either a benefit or a harm. And therefore, to some extent, it has to have some sort of binary relationship to those outcomes. And the problem with some of the risk factors, I would not call them biomarkers, that the indicator cohort produced, is that they are certainly far from being binary in their ability to define outcomes. Again, you may or may not be able to see this, but you can see that for a right ventricular ejection fraction, for example, comparing those that had a bad outcome versus those that didn't have one of those bad outcomes, there is huge overlap in terms of right ventricular ejection fraction. In an individual patient, we simply cannot use it to define whether they are at risk preoperatively of a postoperative bad outcome. And it is true for right ventricular mass and for right ventricular mass volume ratio. Not that these indicators are not telling us something about the signals that define outcome, but we can't use them as a biomarker to define whether we should perform a pulmonary valve replacement on that basis. Now, the age issue, 28 years in this cohort, there's a recent study coming out of the United Kingdom suggesting that age over 35 years is a significant risk factor for one of those hard clinical endpoints, has led some people to say, oh, well, we should just do a pulmonary valve replacement before they get to the age of 25, 28, and then all of our woes will be over. I would challenge that also because we just simply don't know enough. It may be true, but there is an inevitability about doing an operation at a certain point in a patient's lifetime. If I do anything in a patient who's 90 years old, the 10-year outcome for that patient is probably not going to be as good as if I did it when they were 80 years old, simply because they'll die of something else or there'll be something else that will predict their outcome. And of course, it will do nothing if the outcome is already predetermined in terms of time. We're essentially then looking at a time to rather than a time of that outcome. Furthermore, if we just choose to operate on everybody under 28, look at this, of the 400 patients that had no outcome, 200 of them were less than 28 years of age. And so we're going to have to do a lot of operations to prevent outcomes. And the outcome of the operation may in itself, of course, carry its own risk factors. Not such a simple equation than simply doing an operation at a certain age in life. So what about some other things in the last 5 minutes? Well, I think we're just going to have to be much smarter about the way in which we look at these patients. We don't have to throw everything out. It may be true that ventricular volumes don't predict those adverse consequences in their entirety, but other things are helping us to risk stratify. If you go back to the old QRS duration story, this is some wonderful data, I think, from Barbara Mulder's group. What they showed is that if you have a QRS duration of over 180 milliseconds at the time of your surgery, you are much less after surgery than if your QRS duration is shorter, suggesting that that, independent of volumes, might be part of the signal that we need to deal with. And this is also rather interesting data. If you fail to shorten your QRS duration after surgery, perhaps as some sort of marker of electromechanical remodeling, you are also far more likely to have an adverse outcome. 50% of the patients at 10 years in those that did not shorten their QRS duration having an adverse event. Now, others have shown that if you take the QRS duration and add other things like exercise performance, you can further risk stratify. This is nice data from the Brompton group, showing that if you have a long QRS duration and a worse VO2 on exercise testing, you are very unlikely to avoid an adverse outcome in the first few years after pulmonary valve replacement. Interesting combination, I think, of physiologic determinants. And other people are looking at things in a different way. We showed some time ago, actually, that QRS dispersion was almost equally as malign a sign of bad outcomes in tetralogy. This orientation, which is much easier to look at with an expanded standard 12-lead EKG, is also turning out to be a risk factor for adverse outcomes after pulmonary valve replacement, this chaotic QRS fragmentation. And if you add additional risk factors, for example, age, previous shunting, the need for a pacemaker, all of those things add up to an incremental adverse outcome for our patients. And so we ignore it at our costs. Glenn mentioned the impact of the right ventricle on the left ventricle. Nobody should be surprised anymore, although I do think we have rather ignored the left ventricle as a determinant of outcome. We've known for a long time that there is a relationship between RV and LV function. But look at this data from Paul Carey. In patients with an implanted cardioverter defibrillator, the strongest predictor of an appropriate shock was not any of the traditional risk factors that we might consider, QRS duration, ventricular size, but left ventricular end diastolic pressure. It seems that abnormalities of the LV are driving those hard clinical endpoints. And why might that be? Well, this is work from Lars Gross-Waltman from my time in Toronto. The LV, and as we'll see, the RV, but at that time we only really were able to analyze the LV in patients with tetralogy that we traditionally, I think, feel is a right heart disease, becomes fibrosed in many of our patients. Fibrosis will increase stiffness, will increase end diastolic pressure, and one can make up a story at least that the adverse consequences of chronic right heart problems have implications for left ventricular function. That is further supported by these data from Boston, showing that left ventricular fibrosis and right ventricular fibrosis are linearly interrelated. And if you have left ventricular fibrosis or right ventricular fibrosis, you're more likely to have a ventricular arrhythmia during follow-up, suggesting that it's not just volumes, it's not just function, it's not just physiology, but it is the morphology and the integral myocardial structure that might well be driving some of these adverse outcomes, and therefore might be targets in our patients to prevent them. I'm going to finish with this just as a taster for what I think is going to be the most important thing in the next 10 to 20 years of tetralogy research, and that is that the fibrosis that we see in our patients is almost certainly driven somewhat idiosyncratically by their genetic makeup. This is work that Seema et al. Did again while we were in Toronto, showing that, for example, HIF alleles and the amount of them in terms of polymorphisms that we have in our patients with tetralogy of Fallot, for example, drive the degree of right ventricular fibrosis and remodeling that we see in our patients, suggesting that this idea of not just personalized surgery, but personalized medicine within their follow-up is likely to start giving us a much better idea. So in summary, to answer the question, I don't think the guidelines are all wrong, but our guidelines are far from all right when it comes to prevention and prediction of the major outcomes that dog our patients to this day. There's a lot more that I could have shown you, but almost certainly there is an interplay between the residual hemodynamics that are left by the surgeons and that Glenn has mentioned and shown how you might be able to modify by early changes in terms of the initial surgery, the long-term hemodynamics that the patient suffers from, and then the very personal and individual characteristics at a genetic level that might drive ultimately those adverse cardiovascular events. And I'll stop there. Thank you very much.
Thank you, Dr. Beddington. Very thought-provoking presentation. But I'm sure that when we have our next management conference, and I'm sure when everybody goes back to their programs and have their management conference and present a patient with tetralogy of Fallot that potentially needs pulmonary valve replacement, we're going to continue to largely be guided by RV size and functional indices. So clearly, as you discussed in your presentation, there's other factors at play, including diastolic function, including LV systolic function, including intra and interventricular dysynchrony, and myocardial health and fibrosis. And maybe with the RV indices, maybe we're looking at them in the wrong way. And we actually have a paper coming out with one of our excellent fellows, Hugh Ta, where he's looking at a combination of right heart indices instead of looking at them in isolation, and shows that potentially that's a stronger correlate to exercise function. So my big question, and some of the questions that I've seen come across our chat board relate to this, is where do we go from here? What is your takeaway from the current evidence of what needs to be done, and obviously randomized controlled trials and so on, but what realistically can be done to really understand and modify current pulmonary valve replacement guidelines?
Well, first of all, I would suggest that randomized controlled trials will not take us very far forward. But what I do think the case conference in 5 or 10 years' time include will be data from things like the indicator cohort and much larger data sets where we have thousands of patients in follow-up. Now, the indicator cohort was essentially an MRI/imaging-based analysis of outcomes. But we can't just do that. We've already seen that the EKG, exercise, left ventricular and right ventricular fibrosis all play into this. And I suspect all of those have underpinnings in terms of our genetic makeup. So my guess is that our case conference in 10 years' time will have all the same measurements, but it will also have the genome. We'll have an analysis of ventricular fibrosis and the fibrosis burden. We'll understand how that's playing out within an individual patient. And we will be risk stratifying on the basis of all of that integrated data. And the only way we'll learn about that is not from randomized trials, but by machine learning and artificial intelligence applied to deeply phenotyped massive data sets, such that as that we're seeing with the indicator cohort, but perhaps requiring us all as a worldwide community to have our thousands of patients analyzed in a uniform way.
Good. All right. And lastly, I wanted to pull Dolph into this. So you had mentioned the paper that Dr. Michael Hinney and I had written in 2016, where we addressed the pulmonary valve replacement guidelines, but specifically, we tried to relate it to guiding transcatheter pulmonary valve replacement, asking the question, do they seamlessly translate to the transcatheter approach? So Dolph, here we are almost 5 years later from that paper. I wanted to hear your opinion on the threshold for pulmonary valve replacement when considering the transcatheter route.
Thanks, Justin. Very nice talk, Andrew. And yeah, that's complicated in part because primarily what we're talking about in this discussion is the tetralogy patient with a large or patched outflow tract with predominant pulmonary regurgitation. And even to this day, the majority of transcatheter valve devices are much better suited for more into an era where we have self-expanding, larger diameter transcatheter valves. I think we'll be able to understand that better, and we're entering that era now. But I think in general, my thinking is fairly simple and probably fairly simplistic in that if we can put in a pulmonary valve and to some extent normalize hemodynamics earlier, whether it's earlier in the disease process, earlier in life, whichever the case, probably somewhat the same in most patients, without a tremendous increase in either acute or longer term risk, then we should absolutely look at doing that. So I would say that hopefully we'll be looking at how we can push those guidelines into a more, I guess, conservative place as we know more based on transcatheter pulmonary valve data. But I think we're still not there in terms of our understanding yet.
Just a quick point, Dolph. I made the point that certainly for surgical valve replacement, that doesn't seem to be working out. If you stretch the limits, you seem to get more complications. I just want to make one other point for everybody that's listening. I've noticed that there are lots and lots of questions to Glenn and me, and I'm sure everybody else speaking. What we'll do is put together a Q&A based on those, I think, and publish it on Hart University so that everybody's question is answered. We're clearly not going to be able to answer everybody's questions during the course of this webinar.
All right, so we'll move forward then. So our next question will be endocarditis. Should we abandon the Melody valve? And will be answered by one of my mentors, Dr. Dolph Michael Hinney, interventional cardiologist and director of clinical and translational research at the Heart Center at Lucile Packard Children's Hospital at Stanford. Dr. Michael Hinney.
Thank you, Justin. And I will see if I can figure out the screen control issue, just like Glenn and Andrew. Okay, great. Thank you. So yes, I was asked to present on the topic that you just mentioned, endocarditis, should we abandon the Melody valve? And I was struck that this is an unusually pointed and provocative title, one for which I'm really tempted to spoil the narrative suspense by blurting out my answer at the get-go, but I think I'll manage to hold off and work through the data and the argument and get there at the end. So let's take a look at why that concern exists and try to contextualize it within the broader clinical arena and apropos of the theme of this series of talks, the ultimate therapeutic goals in this population, which I think we can all agree are to help provide the best possible chance of a long, healthy, productive life for patients with tetralogy by minimizing risks of premature death, avoidable deterioration, and adverse procedural outcomes, while simultaneously maximizing the beneficial impacts of treatments. To maintain this perspective, I think it's critical to keep this long-term, big picture view in mind, even when we're thinking about individual interventions or therapeutic decisions at any point in life. So for patients with tetralogy and RVOT obstruction or PR, we are inevitably and sometimes perpetually faced with the dilemma of whether and when to intervene on the RVOT. And as Andrew, I think, has very nicely demonstrated, we don't really know, with a good, solid, data-based understanding when that is. And I think it's not going to be the same point in every patient. But until transcatheter valve technology became available, this dialectic really centered around surgical interventional options. And I think Andrew acknowledged that some of the potential offset to any benefits that would accrue may have come through risks associated with procedures. With the advent of transcatheter valve replacement therapies, the first of which was the Melody valve, this calculus became a little bit more complicated, both because of the appeal of the non-surgical pulmonary valve replacement option, but also because there's a whole host of new unknowns. Transcatheter pulmonary valve therapy, for anybody who doesn't know, offers a means of treating both stenotic and regurgitant RV to PA conduits and surgical valves, and sometimes, in it becoming increasingly the case, other post-operative or post-balloon RVOT anatomies. And I would argue that anyone who's familiar with the data should agree that in eligible and appropriately selected patients, transcatheter pulmonary valve replacement offers a very good hemodynamic and clinical result, eliminating PR, reducing RV volume, reducing obstruction to trivial levels, and improving symptoms with really pretty minimal procedural morbidity and mortality. And as longer follow-up becomes available, we're out beyond 10 years now in the early prospective trials, which we'll be able to publish soon. It's also clear that valve durability is generally quite good. So I think, given this context, I wonder why it is that I was given such a pointed and provocative title for this talk. Why would anybody even pose the question of abandoning the Melody valve, even rhetorically, when it seems to be a useful addition to the toolkit? I think it's pretty clear that the fact that this talk was framed so starkly speaks to the perception, at least, that endocarditis in patients who've undergone transcatheter pulmonary valve replacement with a Melody valve is sufficiently common and important to call into question these increasingly established merits of the device. So how do we get to the point where that question is even conceivable? The first case of endocarditis after Melody valve implant was reported by Bonhoeffer's group in a series of 59 patients that was published in 2005. And then that was expanded on in their subsequent report in 2008, in which they reported a total of 5 cases, most of whom had clear predisposing factors. And nobody really made too much of it at that point in time. They were really the only place that people were doing transcatheter valve replacements, and this was the extent of the data on this treatment. But then 4 years later, a group from Paris published a small case series in Journal of Thoracic and Cardiovascular Surgery, which had a somewhat alarming title, coupling the term malignant with melody valve. They described 4 patients, 3 of whom presented with significant obstruction, RVOT obstruction, in the context of endocarditis with typical and usually not particularly virulent organisms. And 2 of those patients died. So it clearly looked like a malignant phenomenon for sure. And I will admit that this was alarming. But this study also illustrates a little bit how potentially off-target patient selection was in some of the early experience, as all of these patients, and this is circled in red, had very small fixed diameter conduits. So a 16 millimeter Hancock valve there for patient 2, or an 18 millimeter Hancock valve, or these are Hancock conduits in patient 3, in adult patients are extraordinarily small. And then once you put a melody valve inside them, they're even smaller. So this doesn't really reflect patient population in whom we would consider putting a transcatheter valve today. And I think this ends up being a pretty good example of how a bigger issue can be framed in a somewhat distorted manner by an early study that is oriented or leans one particular way. Over the subsequent 5 years, there was a steady stream of reports, mostly individual case reports or small case series describing endocarditis after melody valve implants, and the literature was actually somewhat confusing. In 2017, I compiled this editorial review in part to try to clarify some of that confusion. I consolidated all the reported cases, eliminated duplicates, which was about 20% of cases, and then obtained additional details from all of the authors to try to provide at least some consistent and somewhat defined terminology to how we're talking about this issue. And there were a couple of clear takeaways from that survey. First, more than half of patients had what appeared to be prospective insinuability of endocarditis in many of these cases. And second, without any form of either catheter or surgical intervention. And then it's hard to get at in this review, but there's the always present concern of publication bias insofar as the most alarming cases and the presence of the phenomenon is more likely to be reported than the absence. So at this point, it was not really possible to even guess at a true incidence rate for this condition, although we have come further in that regard since. I think, various other reports continue to come out, but I think the article that seems to have had the most outsized effect on our thinking about this issue, if we're looking at the literature, was a series of 79 transcatheter valve implants that was published by a different French group in 2017 in JACC Interventions. The authors in that series reviewed their institutional experience with 32 melody valve and 47 sapien valve implants over 8 years, which is a relatively small experience, and concluded, as you can see up there in the corner, the top corner, that the risk of endocarditis was significantly higher with the melody valve than with the sapien valve in the pulmonary position. This is a strong conclusion, to be sure. I have a whole series of slides detailing some of the methodologic and interpretive flaws of that study, but rather than resorting to those, I think it's simpler and probably more effective to show this quote from the discussion section of a paper that was published the following year by a French consortium, including the authors of that article, which stated, and I read, in a recent study by Hesco et al., the rate of endocarditis was higher in the melody valve group than the sapien group. Because of some study limitations, we believe that the message from the authors should be softened. And then further down, there's sort of the detail, the reasons of why it should be softened. And then I kind of really get to the point, which is that In addition, the included population differed between the groups, making any comparison useless. So this was not a retraction of their prior paper, but it pretty much might as well have been a retraction of the conclusions. So that study was fundamentally flawed, and although the data are of value, the conclusions should not be considered valid. I'm going to skip this slide, but one of the most, I think, significant problems that we encounter when we engage this question of endocarditis after transcatheter pulmonary valve replacement is that almost all of the evidence in the literature has to do with the melody valve. There is very little written about outcomes after transcatheter pulmonary valve replacement with the sapien valve family, which is typically applied in a different population of patients. It's not simply that there's limited literature about endocarditis in this cohort, but there's actually very little quality literature about outcomes of transcatheter pulmonary valve replacement with the sapien valve in general. We just don't know very much. One of the best sources about transcatheter valve replacement, pulmonary valve replacement in a population of comparable patients to those who receive a melody valve was information that was submitted to the FDA as part of the instructions for use for the sapien XT in the pulmonary position. These data are not published in full in peer-reviewed form, but they are available through the public record. And while they're still limited, follow-up in these 79 enrolled study patients, 69 of whom received the valve, demonstrated 86% freedom from endocarditis at 5 years. In our recently published study that included over 300 prospectively followed melody valve implants from the North American and European trials, demonstrated, again, at 5 years, 89% freedom from endocarditis. So based on these two data sets, and again, they're both relatively small in statistical terms for a phenomenon that has an incidence rate of maybe 2% per patient year, it's not clear that the risk of endocarditis after transcatheter pulmonary valve replacement differs importantly according to valve type. It might, but the data don't support that. We don't have a clear handle yet on risk factors for endocarditis within these populations. Several factors have been proposed or identified on limited statistical analysis. But at this point, the statistical power has been really quite small. We're hoping to learn more with an ongoing patients with more than 8,000 patient years of follow-up, and stay tuned for that, hopefully within the next year or so. But one of it, sort of broadening out our consideration of this issue, one of the realities I think that seems to be a little bit overlooked or minimized in discussions of this question is that we're really dealing with a population that is at high risk for endocarditis, regardless of whether a transcatheter valve is implanted. This recent study from Barbara Mulder's group demonstrates poignantly that among adults with congenital heart disease, those with conotruncal anomalies and those with intracardiac prosthetics, particularly valve prostheses, are at far higher risk for endocarditis than any other type of patient. And that's what we're talking about here. These are patients who receive transcatheter valves. And this study out of the UK shows that in patients who've undergone surgery for any form of congenital heart disease, not just tetralogy or conotruncal anomalies, endocarditis and infection are very high on the list of causes of mortality regardless of patient age. So not only is endocarditis relatively common in this population, regardless of transcatheter valve replacement, it's also an important cause of death. And just one more indication of how I think this is an underappreciated problem. This is a study of patients who underwent surgical pulmonary valve replacement that was reported in the STS registry. It was published in the Annals of Thoracic Surgery about 5 years ago, and it showed that 12% of patients undergoing pulmonary valve replacement had a prior history of endocarditis, and that rose to 15% when you were looking at patients with more complex disease who underwent concomitant procedures. So this is a population at risk for endocarditis, period. So as I approach the end of this talk, I would like to point out one potentially myopic approach to decision-making around endocarditis and pulmonary valve replacement that I think we need to be careful to avoid, and which is potentially implicit in the question, should we abandon the Melody valve? This was a study of surgical conduits that really was focused on homografts and the Contegra valve, which is the bovine jugular graft. And this group found that the freedom from reintervention was significantly better in bovine jugular vein grafts than in homografts, as was freedom from replacement, but that the risk of endocarditis was higher in the bovine jugular grafts. And they stated in their conclusion, despite a lower risk of reintervention seen in bovine jugular grafts, these conduits are associated with a significantly higher risk of late endocarditis. And just to note, none of those late endocarditis episodes were associated with death. And they were one of the primary causes of, sorry, this has gone backwards, reintervention in that group. But despite the better longevity at our institution, based on the results of this study, we have decreased the use of bovine jugular grafts in favor of homografts or porcine heterografts. So even though the valve lasts longer, we look at this risk of endocarditis and say, we don't want to use this anymore, despite the fact that it lasts longer, which is, I think, one of the risks that we run when we ask the question of whether we should abandon the Melody valve. So just to summarize and come up with some conclusions here, patients with tetralogy and other candidates for transcatheter pulmonary valve replacement at baseline are among the highest risk populations for endocarditis. To be sure, there is definitely an important incidence of endocarditis after transcatheter pulmonary valve replacement, although most, that is over half of reported cases, are treated successfully with antibiotics alone, and majority of patients recovered after treatment of whatever form. Endocarditis, however, is not unique to the Melody valve among right ventricular outflow tract prostheses or among transcatheter valves, although there are likely unique aspects to this device that we need to understand better. And quite frankly, we just don't have enough data about outcomes of other devices to determine relative incidence rates or unique risk factors or differences in outcome. TPVR, or transcatheter pulmonary valve replacement with the Melody valve, it's technically straightforward, it's clinically and hemodynamically effective, it's low risk procedurally, and there's very good long-term valve function. These are the other aspects of that valve that we need to keep. As we started out, of the right ventricular outflow tract in patients with tetralogy of Fallot is critical, but it's not a single issue proposition. You need to look at the entire picture. And in answer to the question posed in this talk, I would say definitely we should not yet abandon the Melody valve. Where the data takes us, we don't know, but at this point in time, there's certainly no evidence to support that conclusion. Thanks very much.
Thank you very much, Dr. Magdaleni, for outlining all of our current data very, very beautifully there. Obviously, we cannot definitely answer whether the Melody valve carries a higher risk with the current data than with the Sapien valve. But for our non-interventional colleagues in the audience, can you tell us what guides your choice of using the Melody valve over the Sapien valve in your day-to-day practice?
Well, I think for the most part, at this point in time at least, it's largely driven by right ventricular outflow tract or pulmonary valve anatomy, and most importantly, size. There's some overlap in the size range that they're appropriate for, but that's the main driver. So if the outflow tract is a relatively small one, namely a conduit, most patients will still get a Melody valve, in part because we don't know what the Sapien valve, how it really behaves, what the longevity is, what the long-term risks of the Sapien valve and conduits. The data just aren't there. So you can sort of switch to a sapien and say that's better, but that's simply because there's no data to say it's to really illustrate what the problems are. But in larger outflow tracts or larger bioprosthetic valves, the sapien valve is better suited, in part because in some of those the Melody valve just doesn't apply. So I think the size is the main driver at this point. I think if there are other factors that we perceive as being particularly high risk for endocarditis, whether it's immunodeficient patients or prior history, things like that, then that may factor into the decision. But at this point, it's largely driven by size and anatomy, and once in a blue moon by patient or referring physician preference.
Thank you very much. I think as we're running a little over time, we'll go on to our next speaker. It's my pleasure to introduce Dr. Luke Mertens. Dr. Mertens is the section head of echocardiography at Toronto's Hospital for Sick Children. And in addition, Dr. Mertens serves on our editorial board for our Pediatric Cardiac Learning Center here within Hart University. Dr. Mertens is going to talk to us on the title, Why Do We Need Echoes Anymore? Thank you, Luke.
Oh, thank you very much, Jonathan, for introducing me, and thank you for inviting me to participate. I think when I looked at that title, I may have to declare this conflict of interest, in this sense that I definitely have a vested interest in defending echocardiography, but definitely no commercial support to disclose. So when I thought how to respond, like Andrew did, talking about the guidelines, I went to the imaging guidelines on this topic, and there's a beautiful paper published on multimodality imaging on Tetralogia of Fallot patient, which is a joint paper by the American Society of Echocardiography and in collaboration with the Society for Cardiovascular Magnetic Resonance and the Society of Pediatric Radiology. But I got a little bit nervous looking at that guideline paper, which was mainly written by MRI, CT, and adult congenital heart disease experts. So I wondered, what do those guidelines actually say about the role of echocardiography? And if you look at the guidelines, that it acknowledges that 2D and atomic and hemodynamic of Fallot, the modality is relatively inexpensive, widely available, no radiation, and portable. So the guidelines suggest that echocardiography is ideally suited for longitudinal follow-up in this group of patients. They identified, however, some limitations in this sense that echo has some difficulties in visualizing certain parts of the right heart because of restricted acoustic windows. There may be some challenges in quantitative assessment of the right ventricular size and function. And as you know, the guidelines stress a lot the importance of evaluation of RV size and function. And there may be some challenges in quantitative assessment in valve regurgitation. Those guidelines date back to 2014. I wondered, is there any progress in these limitations over the last 6 years? And I'll come back to that later in the talk. So the guidelines also came up with some age-dependent recommendation of imaging modality use. In this sense that they suggested that echocardiography would be the primary imaging modality in Tetralogia of Fallot patients during the first decade of life, and should always be performed before other modalities are used. But once you reach the age of 8 to 10 years of life, that shifts towards the role of cardiac magnetic resonance imaging, and that would become the routine for surveillance of pulmonary regurg, RV size, function, and other things you can read in the guidelines. But they recognize as well that echo continues to play an important role and is a vital adjunct for CMR. Now, is that still true? What does echocardiography actually currently offer? First of all, I think it's the ideal technique to identify, and it's the technique commonly used to identify residual lesions like residual VSD, residual right ventricular outflow tract obstruction. It can also identify the presence of pulmonary regurgitation, tricuspid regurgitation, also quantify at least qualitatively the severity of these residual lesions. I'll go back that there is some evolution in quantification of RV size by echo, and also some evolution in quantification of RV function. Definitely is a good technique for assessing LV function and assessing the ascending aorta, which can dilate. To illustrate this, I thought going over some images and a case of an 11-year-old girl who was operated with a Gore-Tex conduit at 7 months of age because she had a conduit placed because she had a branch of the right coronary artery crossing anterior to the right ventricular outflow tract, leaving the native outflow tract. So she has like a double barrel outflow tract. So the native tract and the Gore-Tex conduit both at the exit of the right ventricle. As you can see, it's pretty easy to evaluate right ventricular function, left ventricular function, excuse me, on using standard techniques, and you can use M-mode, ejection fraction techniques to quantify LV function. For tricuspid valve function, definitely this is a very good technique to assess the presence of tricuspid valve regurgitation, which is quite common after tetralogy of Fallot. And if it's more than moderate, definitely contributes to progressive RV dilation and also potentially RV dysfunction. It's very important to evaluate tricuspid valve function, especially when it's combined with pulmonary regurgitation. It becomes an adverse factor in the prognosis of those patients. The tricuspid valve regurgitation also allows you to assess RV pressure, and the decision to intervene on residual outflow tract obstruction can be challenging, as outflow gradients, as I will illustrate a bit later, don't give you the full picture, as they can be contaminated by the presence of combined lesions like severe regurgitation together with pulmonary stenosis. So that's why it's always important to evaluate RV systolic pressure. In our patient was about just above half systemic RV pressure. Furthermore, the current evolution and the 3D echocardiography has evolved a lot, with providing evaluated by 3D echo images of the tricuspid valve, and allows you also to assess our tricuspid valve morphology. If you want to intervene on the valve, that's definitely helpful. Next, you will see the right ventricular outflow tract in this patient, and it's not difficult to see the two outflow tracts, and you see the pulmonary regurgitation coming from the conduit, and then the residual stenosis on the pulmonary valve that was left intact. As I said, this patient has two outflow tracts. Can you quantify pulmonary regurgitation? Sorry, I have to go back here. Can you quantify pulmonary regurgitation? For sure. I'm going forward again. For sure, you can see in this particular case, you can quantify the jet width in the conduit was an 8mm conduit. Next slide. The 8mm jet measured 8mm as the conduit measured at the time of implantation. You can measure the gradient across the right ventricular outflow tract. It was about 60mm of mercury. As I mentioned, this gives you the good evaluation of the right ventricular pressure together with the TR jet in this patient. Can you further quantify pulmonary regurgitation in other patients? This is another patient where you have severe pulmonary regurgitation, as you can see on this picture, with a free pulmonary regurgitation coming all the way from the branches, with a a very short, sharp deceleration time. So those are the criteria in the guidelines that you can identify patients with severe pulmonary regurgitation. So there is some quantification possible, and the current echocardiographic techniques can definitely identify patients with a moderate to severe pulmonary insufficiency. So that we cannot quantify is not entirely true. It's an important technique for identifying patients with moderate to severe pulmonary regurgitation. What about RV size and function? This is an RV-centric view of the right ventricle in our 11-year-old girl, combined with a kind of RV2 chamber view from the apex, where you can start to assess qualitatively RV function, but you can also add some quantification of RV size and function. One important study from Toronto General Hospital in adult patients after tetralogy of Fallot repair has demonstrated that if you want to quantify RV size by 2D echocardiography, the best technique, the best measurement you can do is RV endostolic area, which correlates quite well with RV end-diastolic volume as measured by MRI, and they even came up with a regression analysis formula, which only works for RV EDV, not for RV end-systolic volume. Mark Friedberg in our group looked at that in children as well, and we came up with a cutoff value of about 20 centimeter per meter square, which identified patients with an RV end-diastolic volume of 100 above 117 mils per meter square. So we can identify by echo using this technology patients with significant RV dilatation who may want to undergo further assessment by MRI. Current technologies have improved on 3D for RV volumes as well, but our experience still is that the automated analysis, which is improved the implementation of this technology, still results in significant underestimation of volumes. And this is illustrated in our 11-year-old girl, where you see that if you just apply, this was an application of the 3D technique, that you likely underestimate significantly the volumes using this technique. So there's still some room for improvement for 3D echocardiography. From a functional perspective, SRV end-diastolic area is a good technique for quantifying size. Fractional area change is a good technique for evaluating function. And the cutoff value for a normal RV function is about fractional area change of about 40%, which suggests a good systolic function. This has been shown in multiple studies to correlate quite well with RV ejection fraction, and it was based on patients with pulmonary arterial hypertension. And this is again from Toronto General Hospital, where they also had a good correlation between fractional area change and ejection fraction by MRI. Now, ejection fraction by MRI includes the right ventricular outflow tract, so this always is lower if there is right ventricular outflow tract dysfunction and dilatation compared to a fractional area change. So it depends whether you want to include or exclude the right ventricular outflow tract in your function analysis. Can you use this for follow-up? And this is the recent data we collected in our patient group, and we looked like Glenn already showed you data on patients with transannular patch versus valve sparing technology, the surgical techniques. You can see that the right ventricles in the transannular patch patients, when you use areas, is indeed larger, and that the values in patients after valve sparing surgery is lower and remains relatively stable. In both patient groups, the fractional area change remains relatively stable over time, at least during childhood, suggesting that their function remains stable. There are other techniques that can be used, like TAPSE and tissue Doppler. I have to warn you that often they are lower in any postoperative patient, and you have to be careful with interpreting those values as values for suggesting that there is a reduction in RV systolic function. They should be used carefully in postoperative patients in general. so I would not strongly recommend. RV strain technology is a technique we routinely use in our patients after tetralogy of Fallot repair, and they add a lot of information. The guidelines from the American and European societies advise to use RV free wall strain. In this particular patient, that again confirms that RV functions are relatively preserved with a value of -20. In addition, strain analysis gives you an idea of a degree of dyssynchrony in the right ventricle. And you can see that in this particular patient, the contraction pattern was relatively synchronous. So apart from function, you also have an idea about electromechanical function. Does the echocardiography and those new technologies have a prognostic value? And this is a very nice study from the Rotterdam group, recently published in JACE, where they looked at the relationship between left ventricular and right ventricular longitudinal strain. And when you look at the primary outcome, which is death and heart failure, you can see that reduction in left ventricular longitudinal strain was significant predictive for outcomes, and also more even important was the reduction in right ventricular longitudinal strain. Also for the secondary outcomes, you can see here that became more important. So it seems like this adds a lot of prognostic information as this technology provides more insight in longitudinal function. And as you know, that longitudinal function in patients after tetralogy of Fallot is probably more important, and right ventricular longitudinal function definitely is an important determinant of RV function. Cannot move forward the slides at that point. Can you move to the last slide? I lost control apparently. So I would like to conclude that echo is essential in tetralogy of Fallot. Can identify residual lesions, can characterize valve function. The quantification of RV size is possible, and it can help you in the serial follow-up of patients. If your end-diastolic area index for body size increases over time, that probably suggests that your RV is remodeling unfavorably. You can have a scenic quantification of RV volumes and a function for sure. And I would like to conclude that MRI is a complementary technique in selected patients, and that echo is the primary technique in the follow-up stages of the tetralogy of Fallot repair. Thank you for your
Great presentation, Dr. Martens. And echo clearly plays a pivotal role in the management and surveillance of patients with repaired tetralogy of Fallot. Dr. Reddington had mentioned the 2018 indicator cohort study, which focused on MRI data, but in about just over 50% of the patients where they had coinciding echo data, they found that elevated RV systolic pressure was associated with poor outcomes. So clearly echo adds valuable information. I think we'll get a little more into that with Dr. Kumar's talk, where he'll talk about what if we don't have MRI at our fingertips. But one of the questions that I wanted to ask you is related to the last study that you discussed by Grudel and colleagues from 2019. You mentioned that RV longitudinal strain correlated with primary endpoints of death and heart failure. In that study, though, they also found that LV apical rotation was independently associated with secondary endpoints. And secondary, they met in addition to the primary endpoints of death and heart failure, also including arrhythmia, reintervention, or cardiac hospitalization. So my question for you is, can you speak more to the assessment of this ventricular crosstalk or interventricular interactions, including any established data of potential importance of assessing this by speckle tracking echocardiography or other echo-based methods?
I think, and that's why the Dutch study is interesting in this sense that it clearly demonstrates that the LV also plays a role, and that it's clearly determined by RV. Because if you look at their multifactorial analysis, if you take RV dysfunction into consideration, LV dysfunction became less of a predictive factor. However, the mechanics, and that's what I showed, became an important, the apical rotation and the lack of it in the left ventricle in certain patients of tetralogy of Fallot suggest that may be an indicator of either ventricular dyssynchrony or unfavorable RV-LV interactions, or a combination of both. I think that's what Andrew alluded to, is that those data provides us a little bit more insight in depth of what's happening in individual patients, rather than just looking at the crude volumes. I find it important to look at what's happening, because if you look at volumes, it includes the right ventricular outflow tract. It's probably more important to look at what's happening in the rest of the right ventricle. And that's what you can do, for instance, based on an apical flow chamber view, where you exclude the right ventricular outflow tract. And then you look at the health of the right ventricle using those novel and more sophisticated techniques. You can study it, how it interacts with the left ventricle as well, because we know that the outcomes is a combination of how both ventricles interact, and that's become possible using these techniques.
Good. Now, coming back to the right ventricle, you had shown an interesting view. You called it an RV2 chamber view. If you rotate a little more counterclockwise, you have a view that your group had published in 2014 that you called a three-chamber view, or an RV inflow-outflow view. And you had established normal data for the transitioning newborns. And a group that I'm working with, we're about to publish where we took that view, we prospectively acquired it in newborns with a pressure-loaded right ventricle pulmonary hypertension, and show that maybe it is a better assessment of RV function. I've always been interested, since that gives you more of a tripartite assessment. You see all three components. Do you think a view like that might be beneficial in assessing the pressure volume loaded RV and Tetralogia flow? Additionally, do you think, you mentioned the deficiencies of three-dimensional echo, where can we improve with three-dimensional echo assessment of the RV?
That's a good question. I think we've looked at this additional views. We struggled, however, with strain analysis of those views, and we struggle with feasibility. So there are still some limitations regarding speckle tracking from this perspective, because we could only obtain, like in 40% of patients where we obtained the views, good speckle tracking. So there's still some technical limitations if we want to look at the right ventricular outflow tract function using echocardiographic techniques. That was at least our experience. For the 3D, I automated analysis in dilate for normal RVs, and not for some very significantly dilated RVs. And I think there needs to be some optimization in endocardial border detection, so that you don't have to do too much manual correction. Because the technique has to be feasible in daily work as well, in daily life. That means it shouldn't take an hour to get an analysis.
Okay. And then we're running out of time, so you have 15 seconds to answer this question. You recently published about blood speckle tracking and its application to pediatrics. It looks really pretty. Your group is trying to show, is there actually application that we can have? Where do you foresee that becoming useful in evaluating these patients?
I think it will become useful for looking especially at diastolic parameters. We have established a newer technique to measure pressure gradients within the ventricle, especially during ventricular filling. As suggested in some of the presentations here, diastolic function, both on the right and left side, may be important prognostic parameters as well. So we hope to be able to better characterize diastolic LV and RV dysfunction using this technology.
Great. Thank you, Dr. Mertens. So we're going to move forward to our fifth presentation out of our six. And so this is Dr. Nico Bloom, and he's going to be answering the question, who should get an EP study or ICD? And he is an electrophysiologist and interventional pediatric cardiologist and head of the Center for Congenital Heart Disease at Amsterdam Leiden. He also serves as a scientific secretary of the Association for European Pediatric and Congenital Cardiology, and which is the main endorsing organization of the Pediatric Cardiac Learning Center, along with serving on the editorial board for our Pediatric Cardiac Learning Center within Hart University. Dr. Bloom.
Thank you, Justin, for introducing me. Here on this slide, you see on the left and right side a self-portrait of Dick Cat, is a famous Dutch painter who actually has a tetralogy of Fallot, as you can see, with his clubbing and cyanosis. And actually, he died at the age of 38 years of age due to ventricular arrhythmia in 1940. And that's the topic of this presentation. Who should get an EP study and who should get an ICD to prevent sudden cardiac death and ventricular arrhythmias? My presentation will be quite controversial because I think we heard a lot on can you click again?
Yep.
Yeah, we heard a lot about risk factors and RV size, LV size to prevent ventricular arrhythmia and sudden cardiac death in repaired Fallot patients. But I think, and that's our approach, you need to go for a more individualized risk stratification. We like to call that a substrate tailored approach, and I will get to that later on. If we look at VTVF in Fallot patients, we know it's a problem. If you look at this Kerry series from circulation, you see that 30% experience VTVF by the age of 55 years of age. And of this group, 10% is an ICD carrier. And on the right, you see what is mentioned a lot, all the risk factors that predict sudden cardiac death, the RV parameters, the LV parameters, the QRS duration, more than 180 milliseconds, transannular patch, older age at repair, non-sustained VT, and at the end also inducibility by EP study, either monomorphic or polymorphic VT is a risk factor for VT. How should we treat these patients that are at risk, or how can we prevent? Well, we talked a lot about treatment of residual lesions like PVR. I put it in brackets because I don't think that's the treatment. ICD therapy can be useful, of course, as secondary and primary prevention are most important two, I think. Medication is less helpful, but can be an add-on to ICD therapy. And catheter ablation is a very useful therapy, either as alternative to ICD or as an add-on to ICD therapy. Brief comments on the PVR in Fallot patients, already discussed by Andrew. Here's the study from Herald in circulation 2009. The message is actually PVR does not impact VT. This is a control group and a PVR group. And here you can see that the PVR group has the same rate of VT as the control group. The indicator study showed the same thing. PVR is not associated with reduced death or sustained VT rate at a mean follow-up of 5.3 years. If you combine PVR with intraoperative ablation, as you can see here in the older study, then you can prevent VT or VF in that group of patients. So if you look at guidelines, either on ICD or on programmed electrical stimulation or ablation, then class 1 indications to implant an ICD is quite clear. You have poor LV function or sustained VT. That's a very common indication. But you can also implant an ICD when you have multiple risk factors like the LV dysfunction, etc. Multiple risk factors, it says. Catheter ablation you can do as an additional or alternative to ICD, and you can should consider programmed electrical stimulation if you want to risk stratify. If you look at the series from Amsterdam, Toronto, and Leuven, in 25,000 cases of congenital heart disease, where there were 213 sudden cardiac death cases, then you can see that these guidelines, these include a lot of Fallot patients, actually guidelines fall short. There are only 35% of that cohort of sudden death patients that had an ICD indication. And if you look at the control group, also 14% had an ICD indication. Furthermore, if you analyze many of these series on sudden death, you will see that although it's a risk factor, the majority of sudden cardiac death in repaired Fallot patients actually have a preserved LV or a preserved RV function. And that brings us to the key point. I think you have to understand the mechanisms of VT in Fallot patients. There are two possible mechanisms, and they can coexist in one Fallot patient. First, it's the polymorphic VT, the VF, which is usually the Fallot patient with a very poor LV function or a very poor RV function, very abnormal myocardium, hypertrophy, fibrosis, dilatation. And it's clear that this more or less standard heart failure patient, you should probably treat them with an ICD. Maybe you can correct some surgical defects, but that's it. More interesting is actually the monomorphic VT group, and that's due to macro-reentrant circuits. And in the Fallot patients, that's usually an outflow tract patch or a VSD patch. And you also need an area of slow conduction. Here you can see how macro-reentrant circuit works with an area of slow conduction. And these VTs are actually amenable for ablation. And you have to realize that these fast VTs also can cause a sudden cardiac death, or if you have an ICD shock. And that brings us to the, I think, a very nice paper of Carey on the ICD therapy already addressed by Andrew. If you look at this ICD cohort in Fallot patients, then you can see that 31% of all Fallot patients in their follow-up received appropriate ICD discharges within 3.7 years. But if you look at the details of that VT, that the VT rate was about 213 on average, range 182 to 264, and that 82 of all ventricular arrhythmias were actually monomorphic, which means that and 70% required an ICD shock. So you have to realize that the vast majority of these Fallot patients have fast monomorphic VTs, and they require ICD shock for termination. And furthermore, often they have a preserved LV and a preserved RV function. So you have to be more intelligent selecting the Fallot patient who is at risk. And I think this is a very important paper by Katja Zeppenfeld from Leiden, from our university, and in combination with Boston group, where they looked at postoperative Fallot patients with VT, and they identified actually that all these patients had 4 anatomical isthmuses that could be critical isthmus for reentrant tachycardia. Here you can see them on post-mortem hearts. Isthmus 1 is between the transannular patch and the tricuspid valve. Isthmus 2 is if you have an RVOT patch, so it's a myocardium between the RVOT patch and the pulmonary valve. And this isthmus 3 is the most important isthmus with that lies between the VSD patch and the pulmonary artery. That's the most common one. And then there's a rare one when you have a muscular VSD between the muscular VSD patch and the tricuspid annulus. If you ablate these isthmuses, your VT is cured. This is how it works in our lab. On the left you see the clinical VT. In the EP study of in the cath lab, the VT is induced. You see similar morphology, similar cycle length. And then you have to carefully identify your substrate by making a very detailed voltage map, very detailed activation map. And so you can locate where your critical isthmus is suspected. Then, of course, you have to prove that by electrophysiological maneuvers like pace mapping or entrainment mapping. Once you identify your isthmus, you can transect it by making a linear ablation site. After that, you have to prove you have made a bidirectional block and that you cannot induce your VT anymore. And we've done that for a large group of Fallot patients, 74 Fallot patients. And if you look at this table, you can see here, no VT was present in 46 patients. VT was inducible in 15, and in 13 patients had spontaneous clinical VT and inducible VT. And what is interesting, if you look at this table, I think it's very interesting that you see that the risk factors do not differ too much between the groups. Of course, what you see is the VT group is older and had an older age at repair, but all the other ones like QRS duration, non-sustained VTs, etc., are more or less similar. And as you can also see, that most of them had a preserved LV and 2/3 had a preserved RV function. All groups had 2 risk factors median. And if you look at the results of that study, then you can see that those with VTs, they have smaller and longer isthmuses with a lower conduction velocity. So that discriminates them from the ones that don't have the VTs. The VT that is mostly related is to the isthmus of the anatomical isthmus 3, as I said, between the VSD patch and the RVOT. And that isthmus is absolutely not influenced by any type of surgery and is also common in the modern era with the young Fallot patients. So it doesn't change, like the big RVOT patch, of course, is not present anymore, but this isthmus is present and remains present in the current era. This anatomical isthmus 3 of these anatomical isthmuses are not associated with the other risk factors like age at repair, time at repair. So it's an isolated finding. If you look at the results of ablation in that group, and I'm not going to go into detail, but the red boxes are interesting. If you have no VT or no isthmus present in 44 patients, or if there is an arrhythmogenic isthmus present in 28 patients, if you go for successful, if the ablation was successful, or there was no ablation performed because there was no VT, that group is group A, 62 patients. They don't have any VT or death during the follow-up. As you can see that most of these patients, some have ICDs, but most of these patients have a preserved RV and LV function. And in the lower group here in red are mostly patients with poor function. So that brings me to the end of this presentation on do we need these EP studies. I think if you look at patients that are at high risk for VT, polymorphic VT, they are of VF polymorphic VT, they are easily identified, and I think they're quite comparable with a normal heart failure population. And ICD or ICD CRT is probably the therapy indicated. More interesting is how we can identify, and that's quite a lot of them, the repaired Fallot patients who is at risk for monomorphic VT. I just said the non-invasive risk factors are not sufficient, like the QRS. Electroanatomical mapping studies are actually the gold standard to identify these patients. And if you have identified them, you can cure them by catheter ablation or surgical ablation of this arrhythmogenic isthmus, and it may even prevent ICD therapy. And then the last slide, I think that's the most important slide. Who should undergo then these electrical anatomical mapping, programmed electrical stimulation for risk stratification? What we do currently in our institution, that patients, follow patients who have some risk factors, and we have quite a low threshold to bring them to the cath lab, but usually they have one or more risk factors. And what we do standard is all patients that are planned for PVR, we do a mapping study prior to surgery to see if there is a arrhythmogenic isthmus, and if it's present, we do a cryoablation on the OR, and we prove bidirectional block in the OR to see that the isthmus is really truly transected. But of course, we have to go for a better non-invasive risk stratification because it's invasive. I think the way to go is that you use your electrical anatomical mapping as a gold standard, but you have to relate it to MRI findings to sort of identify your arrhythmogenic isthmus on the MRI with fibrosis imaging and measuring these areas and length of these isthmuses. The only question that I cannot answer is how this will develop in time, whether these conduction properties of these isthmuses will change during aging. So and I think they probably will. So you probably have to repeat these sort of investigations. So I think in Holland, the only thing the Dutch were able now to see the tulips because of the lockdown, and they're quite empty at the moment. Thank you very much for your attention.
Thank you, Dr. Bloom, for that detailed outline about ventricular arrhythmias and sudden cardiac death in Tetralogia of Fallot. I think most of us would normally send our patients for an EP study when they've already had an arrhythmia or sudden unexplained loss of consciousness, etc. So I was struck by your comments about how everyone so to just be clear, everyone who's going for a pulmonic valve replacement, you do now do an EP study as a matter of course, like we do for our Epstein patients?
Yes, we do actually. Of course, it is an institutional approach at the moment, but the reason to do so, I think most of our PVR patients are teenagers or older, so they're usually not younger patients. The reason to do so is that in our initial data are actually that most of the young patients, they do not have these isthmuses, except for a small percentage. So it is present also in some teenagers. The reason to do so is if you implant a homograft or a bovine jugular vein, you can actually cover this arrhythmogenic isthmus. So if it's present, you cannot reach it anymore by catheterization or endocardially. So that is one of the reasons that we like to know if there is a substrate present prior to the valve implantation. And actually the investigation is not, it takes about 1 hour, 1.5 hours to make this detailed map. So it has become quite a routine for our PVR patients.
And would you do an MRI prior to?
Yes, of course.
Yeah.
And what we try to collect now is and try to correlate is these invasive studies with MRI data with late gadolinium enhancement. So I think that is eventually the way to go. You want to sort of identify patients non-invasively. That's hopefully the way to go in the future. But as I showed you, most of the studies, and it's actually has been shown, I think, by many that this non-invasive stratification is not good enough. It's not good enough to, and also it does not time, but we've seen, and everyone knows it, the Fallot patient with a relatively narrow QRS complex with preserved function who can develop a monomorphic VT. And it's logical because the substrate is there. So you have a substrate. So I think there are two different types of ventricular arrhythmias. I think the very old Fallot patient with a very poor dilated RV with a very low ejection fraction probably is at risk for this more VF polymorphic VT because of the very abnormal myocardium. But there is another group, and I think that's a larger group, is the group that has the monomorphic VT just because of the barriers and the isthmuses.
This is a difficult question for you to answer, but as we're coming to our next speaker, Dr. Krishna Kumar, what guidance can we give our colleagues in lower and middle income countries that don't have the availability to do MRIs and electrophysiology studies? I know it's not ideal, but what predictors of sudden cardiac death would help guide them for AICD placement, for instance?
I think that programmed electrical stimulation in high risk groups and high risk patients with the risk factors that are known thus far is still useful if you can if you have a substrate for monomorphic VT. I think that's not very difficult even in low income countries to do a normal simple EP study. So I think it has a place. in the risk stratification. I think you want to do it more advanced as we do, so as to really find the substrate. But I think in general that an invasive study can be useful for risk stratification and planning for ICD implantation.
Well, thank you very much again, Dr. Bloom. We'll go on now to our next speaker. Our next speaker is Dr. Krishna Kumar, and he's head of the Department of Pediatric Cardiology at the Amrita Institute of Medical Sciences and the Research Center at Amrita University in Cochin, India. Additionally, Dr. Kumar is the section editor of our exciting Cardiology in Low and Middle Income Country content, along with the core section editor, Dr. Preeti Ramachandran from the University of Kentucky, as well as the involvement of Children's HeartLink. Dr. Krishna Kumar will talk to us today about the topic, what if I can't afford an MRI machine? Thank you, Krishna.
Thank you. While I wait for the slides to come on, I have to say it's been a terrific opportunity. Thank you, Justin, for putting this together. My topic is what if you can't afford an MRI machine? And I think I look at my topic as symbolic. I'm not looking at just MRI here. I'm looking at all the pieces of the puzzle that are missing in our part of the world. Not necessarily every institution has all the elements, but there are missing elements everywhere, I think. With that situation, to try and adapt and manage patients with tetralogy of Fallot is the challenge that we're going to try and see if it's possible to have some options emerge. Yes. So the prevailing paradigm has been very well laid out by all the previous speakers. But what's apparent today is that this is imperfect science. In fact, that's what I've learned from the 5 previous speakers. There are so many holes in this paradigm that we haven't filled. We don't understand this completely, and this doesn't completely explain the picture. And I think this is a significant oversimplification. And some of the guidelines on MRI volumes especially have stemmed from this oversimplification. And clearly, they don't seem to work very well. Now, when you take an imperfect science and try to apply it to a low resource environment, it gets much harder. Than even in a situation where you have a perfect science. And in much of our part of the world, simple heart defects being cured. And you take something as complex and imperfect as this, it becomes even more challenging. So if you start, this slide actually maps the journey of a patient with tetralogy of Fallot in our part of the world. So the initial operation, which I've put corrective within quotes, of course, we know it's not corrective anymore, followed by is usually preceded by a counseling, and there are some expectations that happen after with the family. And then after the surgery, there are follow-up visits, and then there are tests on follow-up. There is PA rehabilitation. There is also a whole bunch of EP issues that I didn't want to put in because the slide got too crowded. And then eventually there is the stock of PVR. There is the first PVR is almost inevitably a surgical PVR, and that has reduced anatomy, and then it goes on to a degenerating PVR and a percutaneous valve. Now, with this sort of a situation, we have several problems. We first start off with not many babies having surgery in the first place, and that's reflected by the fact that the average age of surgery is much older, and that turns out to be a significant risk factor. And then, of course, at the initial conversation, especially, I think we are all guilty of this in our part of the world. Perhaps maybe 20, 30 years ago, when you spoke to your patients in the West, there is this perception of cure. The family thinks that this is the only operation. So even if you sort of broach the issue of a future PVR, it somehow slips away from their consciousness. What we don't do is to walk the whole journey with them. The whole journey, when you walk through with them, it's quite likely that many patients would say no to the first operation. But then there are resource constraints that prevent follow-up visits. There is lots of logistic financial difficulties. And it's not just MRI. We don't do the proper exercise test, for instance. We don't actually measure oxygen consumption in most circumstances because that takes a lot of time and personnel and resources. And we don't have that. And we don't actually do a good job with rehabilitating pulmonary arteries in all circumstances because we don't have stents. We don't spend enough time in investigating vulnerability to arrhythmias. And then when we actually reach the point where we, let's say, even if we do the MRI and talk to patients about pulmonary valve replacement, there is this question from the family as to whether it will eliminate risks. And we are not very good at answering that because we are not convinced ourselves. And we've seen that today, that we're not sure how much it benefits the patients in terms of true survival. It may improve functional capacity. So if we come up with sort of nebulous answers, a lot of the patients don't seem to be convinced about the reoperation. Nonetheless, even in the small fraction that undergo reoperation, they want to know how long the solution would last. And the prospect of another 3 pulmonary valve replacement or maybe percutaneous valves is daunting. The cost of a single percutaneous valve, the Melody valve, is not so melodious in our part of the world. It costs as much as 10 open heart operations. So there is a real issue here in terms of how we can help our patients. And you can see clearly that pulmonary valve replacement is only one part of the solution. And I think you'll be convinced from the previous lecture. I was convinced that I think we need to investigate patients' vulnerability to arrhythmias. And it's probably a good idea to do an EP study and do an ischemic ablation prior to PVR. It makes a lot more sense because you provide a comprehensive solution. So our solutions really, this very imperfect situation translates into even greater challenges in our environment. So when we looked at our own database, we've been operating since my center at Amrita Institute has been functional since 1998. And in the first 7 years, we may have done about 900 patients at the short. I don't have the exact numbers because the database is a little old now. And of that, we actually started to look at our MRI database. And of these 900 patients, 131 were continuing to come on follow-up. And of these, 84 were candidates for PVR based on the indications that we've just discussed. And we actually did PVR only in 34. We used percutaneous valves in 3 and we replaced them surgically in 34. And when you look at the right side, the numbers of the volumes that are apparent to you, of course, the average age of surgery was older, as you can imagine. We were actually, the age of doing the MRI, the first MRI was relatively not too bad. I mean, about 10 years or 12 years later. But most of the volumes, the median volume was 160. So a lot of the patients had reached pretty high volumes by then, both systolic and diastolic as well. So this situation clearly tells us that going by the current criteria, we've reached a point where many patients are already quite late in their unmodified natural history. About MRI itself, yes, we actually have MRI for the last 10 years. We have some very bright and talented people. Mahesh is my colleague who does the MRI, and I think many of the audience know who he is. Dr. Rajesh Kannam is the radiologist who assists him, and they work together very well, and they are able to do it. But it just shows what you need. You need the machine. You need the people who can run the machine, the personnel, and often that's a team of that involves a cardiologist and a radiologist to get the best kind of result. It costs money, and these guys have competing clinical demands. Both of them have serious competing clinical demands. Mahesh does CATs, he is in the ICU. There's a lot of things to be done, and the time taken to interpret and report really consumes them considerably. So this is a real issue. Even if you have an MRI, it's not so simple. And then, so what do we do for centers that don't have MRI? These are the real world adaptations. They are getting the radiologist alone to do it and doing focused, just simple focused examinations for just volumes and functions and not trying to do the whole comprehensive MRI that can take much longer time. This can be done in 20, 25 5 minutes. And then replacing the pulmonary valve at a fixed interval after initial repair, not worrying about volumes. And this was discussed by Andrew and others. It seems a bit crude and simplistic, but that's one option. But the option that really ends up happening, and I would say it's not an adaptation, it's a compulsion. The vast majority don't get the pulmonary valve for the reasons that I have outlined previously. But I think we should not be so pessimistic or negative. We need to actually look at what's best available. And I think the talk by Luke really made me think a lot today. I think we need to think much harder about making the best of echo. And I don't think we've done a good job. And I think we've lost an opportunity in our part of the world in actually doing systematic echocardiograms and collecting the entire gamut of data and looking at it very comprehensively, not necessarily 3D, but just the 2D indices that Luke outlined and perhaps a few more indices and putting it through a very comprehensive way of analysis. So we need to do that. The other things are, of course, straightforward, and we have it readily available in our part of the world as well, and they can actually substitute for MRI quite easily. What's attractive about MRI is that all this just comes in one single investigation, which is why everybody likes MRI. But that's not realistic, and for the reasons that I have outlined. And not to forget that the assessment of arrhythmia risk is really independent of all this, and that needs to be done. Very often we just say that we don't have MRI, so we don't look at everything else. That's not the way to do it. We can do a lot, even in the absence of MRI. So the future directions really, I think there's something that we need to think about. There's not much that we can say for the present. There's a lot we can think about the future. Fine-tuning of the primary repair, and I think Glenn's talk set the stage for it. We are doing valve preservation in our institution close to 70 to 80%. We are able to avoid a transannular patch, and that's going to be the real way to move forward. Lowering costs of MRI machines may not happen. It's beyond our scope. Widening the training base, having more people look at MRI and training them offline, remotely, like how this is happening, this webinar is happening, is some way of actually trying to improve the skills and widen the skill base. Improve 3D echo technology, maybe. It's taken a long time for it to evolve. But I think this is what excites me most. I think the simple echo surrogates can be put into an AI-based algorithm. I think we can come up with answers that can be pretty exciting. I think we need to question this holy grail of MRI. It's clearly not a holy grail. I think there are elements which are too simplistic, and we need to question this whole paradigm altogether and come up with something that maybe will be an answer for everybody everywhere in the world, not just for the low and middle income countries. And then I think there are disruptive innovations that may change it all. We can actually have really, low-cost catheter-based valves. And this is wishful thinking. The venous P valve came in as a low-cost valve, but it's become expensive, and it's got very limited scope. But we can come up with something more exciting, and that may change the whole paradigm. We may actually, replace pulmonary valves much earlier. Thank you.